Alrighty, folks, I'm going to get us started. For those in the room and to those on Zoom, hello and welcome. I am absolutely delighted to open this joint lecture between the Yale School of Public Health and the Division of Geriatrics at the Yale School of Medicine. As many of you in this room know, our School of Public Health and the Division of Geriatrics, including the program on aging, have a tremendous history of collaboration spanning many decades and many deans. This joint lectureship, which was started by Dr. Tom Gill and by one of my predecessors, Dean Paul Cleary, who I don't see in the audience, but is hopefully online, dates back to 2012 and is one of the many wonderful things to come out of these years of partnership and collaboration. I'm looking forward to continuing to grow it and amplify the work for decades to come, even as our school goes through the process of becoming its own independent school. So you all know this, and I know that Dr. Freed is going to talk about this in much more detail, but according to the World Health Organization, the pace of population aging has reached near record rates, and 80% of older adults will be living in low and middle income countries by 2050. So this is an issue not just for us here in the United States of thinking about healthy aging and longevity, but also on a global basis. In order for us to approach our aging population with a sense of full body, emotional, physical, and social health, it is going to require us coming at it with many of the precepts of our school: innovation and entrepreneurship, inclusivity, data-driven leadership, and of course, excellent communication. It's going to require rigorous science, excellent clinical care, and most importantly, it starts with us, meaning the strengthened and continued collaboration of our schools and of our fields at large. So with that, I cannot say enough great things about Dean Freed, who I know that Dr. Freed is going to introduce in a moment, but it is truly a joy and a privilege to welcome you all here today, to welcome Dean Freed, who has been a longtime inspiration for me as a public health leader, physician, and researcher. I'm very much looking forward to your talk. And I will turn it over to Dr. Terry Freed to introduce Dean Linda Freed.
Thanks so much. Just so that I want to make sure people know, I'm actually doing this introduction on behalf of Dr. Gill, who I believe is joining us on Zoom, but couldn't be here with us in person today. So I just want to take a moment to recognize Dr. Gill's able and wonderful leadership of the program on aging and his work to establish this lectureship, which is a partnership between the program on aging and the School of Public Health. So acting in Dr. Gill's stead, I'm here to introduce Dr. Linda Freed. I really could eat up the entire time of her talk to do a full introduction, but I really want to hear her talk, so I'm not going to do that, and I'm going to attempt to just hit the highlights. Dr. Freed received her BA in history from the University of Wisconsin-Madison, and then received her MD degree from Rush Medical College, where she also did her internal medicine training. She then went to Johns Hopkins, where she did a fellowship in geriatrics and received her MPH. She joined the faculty then, both at the School of Medicine at Hopkins, as well as the School of Hygiene and Public Health. She was the founding director there of the Johns Hopkins Center on Aging and Health, and in 2008, became the first female dean of Columbia University's Mailman School of Public Health, where she's also the D. Lamar Professor of Epidemiology, Professor of Medicine at Columbia's College of Physicians and Surgeons, and Senior Vice President of Columbia University Medical Center. Just to name a few of her awards, she is a member of the National Academy of Sciences, a member of the Association of American Physicians, has received the Silver Scholar Award from the Alliance of Aging Research, has received the Alma Marani Renaissance Women's Award from the Women in Medicine Legacy Foundation. And I think perhaps the most recent award is the recipient of the Kober Medal from the AAP. What's really extraordinary about Dr. Freed's work is that she has made such profound contributions on so many levels. both to the basic science of and the policies and around aging. So you can't study something unless you can measure it. And Dr. Freed figured out how to take what was previously a really nebulous concept of frailty and turn it into a measurable phenotype. And I cannot tell you the number of times early in my career that people would say, "Oh, you're Dr. Freed." And I'm like, "No, I'm the other Dr. Freed." "Oh, you're Dr. Freed. You did the no, other Dr. Freed." Definitely was my early career. But so Linda developed the eponymous Freed Frailty Index. And after the development of that, was really able to demonstrate frailty as a geriatric syndrome, understanding both its causes and precedents, and also understanding its association with outcomes. And the paper that presents the Frailty Index has actually been cited over 15,000 times. While at Hopkins, she was also the PI for major longitudinal studies, providing us data about aging, including the cardiovascular health study and the women's health and aging studies. At Hopkins, she was also the co-designer and the co-founder of Experience Corps. Experience Corps is a nationwide volunteer program training adults age 55 and older to work with students in economically disadvantaged groups to benefit both the older person and the students. And in 2022, she co-chaired the National Academy of Medicine report, The Global Roadmap for Health Longevity. Some major initiatives since her time at Columbia was bringing the Butler Columbia Aging Center and developing the Interdisciplinary Center on Climate Change. I'm just going to finish letting you know that in 2012, Dr. Freed was profiled in the New York Times, where they profiled 15 particularly impactful and important scientists. And I actually wanted to share with you some of the things that people had to say in that article. Christine Castle, who at the time was the president and chief executive officer of the American Board of Internal Medicine, said that Dr. Freed's work, quote, has become core knowledge and core teaching in every geriatric program. And I can say that that is true. And it is amazing when we hear all of our medical students and residents really having incorporated this notion of frailty as a key geriatric syndrome. Kenneth Rockwood, who had developed a competing tool for the identification of frailty, was subsequently invited to serve on the external advisory board of the Center on Aging and Health at Hopkins. And his comment was, quote, "How many other people invite the guy on the other side to come to their program?" And I think that says a lot about Linda, who has been a fierce advocate for junior faculty and particularly women. I don't know, Linda, if you'll remember this, but it was one of those like very difficult periods in my I think I was transitioning to mid-career and, you know, the funding issues, whatever. And this was not true, but Dr. Freed was gracious enough to say to me, "You know, Terry, sometimes I'm becoming the other Dr. Freed." It was the nicest thing that anybody could have shared with me. And I appreciate that to this day. So with that, I turn the podium over to Dr. Freed.
Well, good. Let's see. I guess I could say good afternoon. Terry, that was an unbelievably generous introduction. Thank you. And I see so many longtime friends and colleagues here, and I'm just so happy to see all of you. And Tom, I'm sorry you couldn't be here in person, but if you're online, you know, so much of what we do is in your image. So thank you. So I would like to talk to you about the business we're all in, which is a business, whether you're in medicine, I used to be a chief of geriatric medicine, or you're in public health. What we have done is we have, through intentional societal investment over the last 100 years, created something unprecedented in human history, which is longevity. human longevity. And I would like to say to you that the core responsibility of both medicine and public health, or both public health and medicine, wherever you sit, is the creation of health through our longer lives. It's both our responsibility and the opportunity of the 21st century. And I'd like to talk to you about what that could mean and why we could do it and why we must do it. So let's see if I can make the slides go. So I'll start out by saying that we are actually in a demographic revolution. Think about the fact, and this, if there's any group in the world that knows everything I'm about to say, it's you, but so I apologize. But just to start with a little data, which Dr. Dean Rani already did. In the US in 1900, life expectancy at birth was 47. And if you were African American, it was 36. In 2010, close 79 years. And by 2018, just before the pandemic, it was closer to 80. That is an astounding addition of over 30 years to human life expectancy in the last 100 years in the US. And right now, if you look globally, because this is happening globally, and you add up all the numbers of people who have ever lived past 65 in the history of the world, there are more older adults alive around the world, just as Dean Rani was suggesting, than have ever lived before in human history. So we're at an unprecedented moment where people are already living a third of their lives after what we call retirement. And last year, the US crossed the threshold of becoming an aged society because we now have more people over 65 than under 15 for the first time in human history. And that's the definition of an aging society. So we are going through, hence these data, I hope, support my proposition that we're going through a demographic revolution. I don't have the time to lay out all the other dimensions of that argument, but just think about adding 30 years of life expectancy at birth. What we've done, you could think of as adding a new life stage. The question is, what will this mean? So obviously, one thing it means is that if people are living longer, it changes the population structure, and you all know that. You know, but we've gone from 4% of the US population over 65 in 1900 to now almost a fifth, and by 2050, a quarter of the US population will be over 65. And in many states, it'll be more like Japan, like Florida, it'll be 40%. Florida's almost there already. How do we get there? Well, this is very important to think about because this was not a given. And we're in a stage we never defined before. We got here through what our demography colleagues would say are two predictable transition phases, a first demographic dividend and a second demographic dividend. The first demographic dividend, as it says on the slide, is a period that we see primarily in agricultural societies of a transition of declining because of improved investments in health and in education, a decrease in infant and child mortality, and subsequent to that, and in response to that, a dramatic decline in fertility and the numbers of births per woman. And it has gone globally from 5 to 2.5 from 1950 to the present. That's astounding. And we expect it to go down to 2 globally by 2050. And what happens at the conclusion of the first demographic dividend is that you see a bulge of children who are actually surviving childhood and are merging towards adulthood. That sets up the stage for the second demographic dividend, which we primarily see in industrialized societies. But really, almost every country in the world is currently in a second demographic dividend, where we see basically persisting declines in mortality and fertility because of improved survival into young adulthood with more health. Countries experience a boom in terms of a healthy and productive young adulthood that powers their workforce. And a huge number of young adults relative to the populations we currently call dependent, namely children and older adults, creates a lot of the potential, if those young adults can get jobs, for economic wealth, which enables a society to invest further in its human capital, in health and in education, and really powers the thriving societies. And the US experienced that after World War II. With improved survival, you get the population living longer. The age structure starts to change, and we're veering toward equal proportions of people in every age group with that change in the age structure. And there's one more asset that economists have said we develop in the second demographic dividend because we have more older people. It's the only asset that's ever been defined as being part of as the benefit of having longevity. And that is that people have more years to save and more compulsion to save because of the need to pay for retirement. And so this accumulation of lifetime savings is also an asset. So this is as far as we have gotten in thinking about what it means to have added 30 years to human life expectancy, except for the Reagan era and post-Reagan era hanging of crepe on the fact that there are more older people around. I'm happy to talk about that at length, but not at the moment. Now, as Dean Randy said, this is a global phenomenon. What it took, if you look, this on the top is dates from 1860 to 2040. On the y-axis are the proportions of the population 65 and older. And what you're looking at is the length of time it took for different countries to go from 7% of the population to 14% of the population being 65 and older. For France, it took 120 years. For Sweden, it took about 100 years. For the UK, it took 45 years or so. For the US, it's taking us about 40 plus years. But look at South Korea, China, Thailand, Brazil, and a host of other countries. They are going through transitions to being aging societies in 20 years that the West and Japan took 100 years to do. And so what this means and what the implications are and what the opportunities as well as the challenges are of this demographic revolution is squarely in everybody's camp, but at a speed that is almost breathtaking for some countries. So what do we want with this? Well, we've had a lot of ideological positions about what this means, but not a lot of asking older people or any of us at any age what we want for older age now that we've created it. And if you look at the data, what both young adults and older adults say they want as they get older are health and well-being, security, both financial and safety, the right environment to age in place, which most people would say is in a community and in their home, a community of people that they're connected with, and the opportunity for cohesion with others and social connection, and the opportunity to get up in the morning with meaning and purpose. and the ability to give back in older age and leave a legacy of having made a difference that will live beyond you. That's what people say. It's not what's in the papers. And the other thing that we have learned through studies I don't have time to go into today is that what people want, the obstacle, a huge obstacle between what people want and what we have right now is whether or not people are healthy and whether or not they are disabled in particular. So health status during older age is turning out to be determinative of people being able to achieve the opportunities that they want associated with being older. And I will argue those opportunities could translate into profound opportunities for societies that have the benefit of long lives. So I'm sure this audience knows this, but we often start with saying, well, what could having a more or a less disabled population that's aging mean for us? And we look at scenarios like this hypothetical one, which is a slide that Jack Gorelnik created years ago and gifted to me. So I have to credit Jack for those of you who know him. But let's just think about, if this was 1990 and you had a life expectancy verging towards 80 years, and a large proportion of those years would be spent in the green in health, hopefully, at a population level, and a certain proportion in red in years with illness and disability. Now, what could we expect going forward, and what would that mean? Well, one scenario could be that life expectancy continues to expand. Let's make up that it goes up to 83 years in a few years. And the total amount of years in green expands with health, but and there's no expansion in the number of years lived with disability, same number of years. What's an alternative scenario? Well, one would be that life expectancy expands and health expectancy expands, and years lived with disability actually decreases. Not just the proportion of years in disability decrease, but the actual years in disability decrease. A situation that we all call compression of morbidity as the major public health and medical care goal for the world. A third future scenario could be that life expectancy does expand, and this doesn't even take into account the decrease in life expectancy since COVID, but I'm speaking theoretically here. Life expectancy also expands, but the number of years people are living with illness and disability also expands. What we could call a decompression of morbidity. Which scenario would we vote for as a society? Well, that's a self-obvious question, right? We vote for scenario 2. Which scenario are we seeing? We're seeing scenario 3. More ill health over more adulthood years. And what we're seeing is actually a widening gap between our healthy life expectancy and our life expectancy. US data, and this is just for 2011 to 2018, is that at age 65, life expectancy for males is 17 years on average, and the healthy life expectancy is 8 years. And for females, it's 19.7 versus 11.3 years, a wide gap. If you look globally, the healthy life expectancy to life expectancy gap goes as high as 38 years. That gap. And we're seeing globally as well as here, more and more adults living more and more years with ill health. If you look at subpopulations in the US, and here I quote from Doug Miller and Fred Walensky's, what I think is a landmark study of inner city African Americans in St. Louis, center city St. Louis, and suburban St. Louis, who were compared to white Americans in suburban St. Louis. What they found is that inner city African Americans develop clinical and subclinical disability as well as chronic disease and multimorbidity 10 years before white Americans in the suburbs. And that Black Americans in the suburbs were intermediary and between the inner city African Americans and the whites suburbans in terms of when they became disabled. So that's the scenarios that we're confronted with, database scenarios. We have other scenarios about why we should think about this and say, is this what we're stuck with? And the one I'd like to argue with you today is that if we accomplished a decreased gap between healthy life expectancy and life expectancy, if we compressed morbidity, if we extended health span for everybody, what could that unleash? Well, there's some obvious answers. It's individuals prefer to be healthy than sick. That's sort of obvious, but incredibly important. There's a response that if people arrived at old age healthy and stayed healthy, and then were positioned because of that to stay healthier through their older age, and we invested in keeping them healthy, using the data we have, we'd have a diminution in healthcare needs and costs, which at this point is straining the US and many other nations' budgets. But I would argue that if we invested so that people arrive at old age healthy and stay healthy, we could unleash the as yet unrecognized opportunities of the longer lives we've built, because we did create them. And what are they? Well, I'll argue to you that older people turn out to be the world's only increasing natural resource. And I'd like to show you that older adults bring all of us. I hope this is a good news story. But as we get older, we actually achieve capabilities and assets that we accrue over our lifetime that could signal that the social capital of an aging society could be the greatest asset any society could have for societal thriving. And that if we enabled the unrealized social capital of older people to do what they want to do, which is to give back, and if we appropriately valued what older adults can deliver and enabled it, that this could uplift society's future and get a virtuous cycle benefit of enabling people to be even healthier, because the data is compelling that people who stay engaged stay healthier. So that's the thesis I would like to apply with you for our remaining time, and then to argue what the implications could be. So let's start with the members of one of the newest global organizations in the world, the youngest global organization in the world. It's now 13 years old. No, I'm sorry, my timing is off. It's now actually at the age of majority. So that's the elders. Has anybody here ever heard of the elders? So let me introduce you to the founding group of the elders. Nelson Mandela was the president of the elders after he stepped down from being the president of South Africa. You can see Desmond Tutu, Jimmy Carter, Gro Harlem Brundtland, Mary Robinson in the back, who's the current president of the elders, and many others. The elders are statespeople who stepped down from their formal statespeople role and came together as a group to try and affect the future of our world and of our nations. If you want to have an uplift Google them and then get on their mailing list, because they put out mailings every week on the issues that they're working on. And they have been the prime leaders globally on giving voice to young people on climate change since 2009. So think about the social capital represented by this group. A little awesome, I would say, and highly inspiring, but not the image of what most people carry around in their mind when they think about aging. And in fact, they represent what the science says are the assets we accrue as we get older, which I think is not sufficient. That science is not sufficiently developed, but developed enough to take my breath away. What are those assets? Well, first of all, and the people in this room are prime examples. The day you turn 65, you will not lose all the knowledge you have accrued by then. The data is strong about that. You will continue to learn and grow and develop and become ever more expert. You will not lose your ability to have impact in how you talk about it or what you're trying to affect. But in addition to that, you accrue other assets which make that even more powerful. Because as we get older, we have had a lifetime of experience, some of it quite adverse if you're alive. And as people get older, they learn from that. And they also develop abilities to integrate their subjective life experience learnings with their objective expertise, and to develop values-driven approaches, not just to what they think is right, but how to put together the subjective and objective to solve problems more effectively and humanely. And a lifetime of problem solving turns out to pay off, because in fact, there's very intriguing evidence from cognitive scientists that as people get older, not everybody, but many older people demonstrate logical capabilities for complex problem solving that they did not have when they were 20, 40, or even 60. The ability to recognize complex problems, to decide from a values-based point of view if they're important and they matter, to then break them down, if they matter, to spend enough time on them, to break them down into their actionable parts, and the patience as well as sense of urgency to hang in there to get them solved. These are assets that we are in short supply of, I would argue, and could come in very handy. In addition, and they underpin kinds of creativity that emerges as people get older that we don't have when we're younger. In addition, Laura Carstenson's another work has demonstrated quite convincingly that as people grow older, they become not just happier, but more emotionally stable, more optimistic as people, and more pro-social about caring about the welfare of others, and more generous to do everything they can to support better outcomes. In fact, if you roll that all together, I would say that at the goals and need to give back of the older population makes older people, I would say, defines the stage of older adulthood as the pay it forward stage of life. If you combine that with social capital, with these kinds of capabilities, which we throw away, if we didn't throw away, if we knew how to value these capabilities, which we don't, and we built the social infrastructure for people to meet their goals of giving back, using the assets that they have and not the assets they had when they were 20, then we would have a force for societal thriving that could be unprecedented as well as powerful. The key in the lock on this is an adequate amount of health and function. Now, I'll stop to give an advertisement, which I don't have time to talk about today, but as Dr. Fried mentioned, the National Academy of Medicine issued a report in 2022 called the Global Roadmap for Healthy Longevity. I had the privilege of co-chairing this report, but it lays out in large detail what we have to do to create healthy longevity, what public health better do, what medicine better do, what every sector of society has to do so we transform the creation of longer lives into the opportunities of longer lives. So I'd like to talk about what I mean when I say that older adults offer a potential social capital that the world has never seen before. And most people don't have a background in thinking about social capital. So I'd like to just offer you some definitions. Social capital is what we're talking about when we talk about the human connections that create the fabric of a cohesive society, a flourishing society. Bridging social capital is about the connections between people who are not like you in your community. Bonding social capital is about the connections you have with people here next to you or in your community who you share identities with. Linking social capital is the connections that we have with people who are at different points in the socioeconomic ladder, which has been shown is the opportunity for youth to have connections to people who are higher on the socioeconomic ladder is a clear and essential pathway for social economic mobility. These three are basically the fabric of a community. The ability to have somebody you can borrow a cup of sugar from. The person you can go to who you may not know well, but you know they know somebody who you want to meet. The people you might form a book club with. The people you might actually go in a walking club with. What Mark Granovetter in 1979 called the strength of weak ties, which create a cohesive society, even if they're not your best friends. And then there's a new term called structural social capital. And this is actually the structural social infrastructure that enables people to come together, to find each other, to create collective efficacy, to address shared problems, to take solutions that an individual can't accomplish alone and bring them to impact. And there's been a lot of work in the last 20 years, and probably Robert Putnam is the most famous person to talk about this, about the fraying of our social infrastructure that brought people together in so many ways, which maybe have frayed because it was anachronistic to the life of the late 20th and 21st century. But we are without it in large degree. And Dean Ranney works on a lot of the consequences of that. And when she talks about gun violence. So I would say that in the US, if you think about what we already have in terms of people who have visible participation as social compact through volunteering organizations, which is a little different than social connection without a volunteering kind of purpose. We already have 29 million older adults who volunteer through an organization who contribute 3 billion hours of service to their community per year. That's pretty impressive. But most older adults in the US can't find roles that value what they have to offer or that address the things they need solving, and are sitting on waiting lists from to find a role in the ones they want to be part of. And many more older adults do report, and I've done research on this, so I don't have time to show you the data, but many more older adults report desiring to be engaged in formal ways in volunteering than they can, due either to their disability, much more than just having chronic disease, or to the inability to find impactful roles that are worth their time. And also not having the means to support the costs of volunteering. Even just getting from place A to place B is costly. In fact, at a large level, old age has been described as a role-less role. And we have a huge need to create societal roles for an aging population, which could, I think, amount to a win-win to transform the unprecedented potential social capital of older adults in an aging society, which is what I've been trying to describe to you, into realized social capital. Realized for the individual who needs to give back, and realized for society, which is impoverished without these contributions. So I'd like to offer you evidence from the first such attempt to do that, which is called Experience Corps. And I had the pleasure as well as privilege of creating Experience Corps, and learned the need of this from my own patients who too often were sick because they had no reason to get up in the morning and no role for that last third of their lives. And I designed Experience Corps to demonstrate that we could build a new social infrastructure that would create, not just make do roles for older people, but high impact roles for older people in society. As volunteers, there's also roles in the paid workforce that we should think about, but roles that harness this unprecedented kind of social capital to solve, Lord knows, the gazillion societal needs we have, to do their part in solving that, while also meeting the goals and needs of older people in the same design. So a societal approach that could be embedded in every community to meet the needs of older adults, to give back, to fulfill their generative goals and desires, to recognizing older adults as assets, and to build the opportunity for social networks and connection and community that most older people are deprived of in most communities because of the fraying of our social infrastructure. And at the same time, Experience Corps is designed as a public health program to prevent frailty, cognitive decline, and disability in a context of engaging in things you deeply care about. And because it was designed to be delivered in every community, and particularly to target, at least for starters, at-risk children, it has attracted hosts of older volunteers who also come from the communities with huge health disparities, and has the potential to be a vehicle for solving health disparities at scale in communities. What's the evidence? Well, let me just tell you about the design. It's a high-intensity volunteering program for older people. Older adults have to commit at least 10 and better 15 hours a week for the full school year. There's lots of reasons for that. Some of them is that that's what it takes to be a trusted member of a public elementary school community, entrusted with the children. And that's what it takes if you belong to a gym to become fit and to get an adequate dose of prevention. We designed high impact roles for volunteers, not for teachers, not for paid roles, but for volunteers, using the assets of older adults in public elementary schools, because if children are not succeeding by 3rd grade, they're tracked to drop out of high school. And so to improve the academic success of every child, not just 2 or 3, using the assets and meeting the goals of older adults, shifting outcomes for children in schools, being a force for social benefit in communities, a program designed to build social networks and friendships among the volunteers, and to promote health. And I would say with Becca, to counter ageism by demonstrating the huge value that having more older adults in society brings. Here's this is Mr. Donald O'Carroll. He passed away a few years ago, so I can use his name and I'm not violating HIPAA. This is one snapshot of what Experience Corps looks like. You'll notice that you can't see this, but he was a bilateral amputee due to his diabetes and he's sitting in a wheelchair. What's the impact of Experience Corps on children's school success? Significant improvements in school behavior, academic achievement, school climate, and in teachers' sense of efficacy and potentially of teacher turnover, which is 50% in 5 years in public schools in the US. Here's another snapshot of Experience Corps. We have done a lot of research to demonstrate that the model that we designed, which I really don't have time today to tell you all about, was designed both to deliver roles with impact and health promotion with impact. Intervening on the 4 core risk factors for health and aging: physical activity, cognitive activity, social activity, and social engagement for generative impact. The outcomes we're seeing are quite exciting. We're seeing that all 4 of those risk factors are markedly improved, and that the outcomes include, for example, improved mental executive function in volunteers with low normal executive function to start with, brain activation in prefrontal regions, prevention of memory loss, and improved strength, lower depressive symptoms, new social networks, and a sense of fulfilled generative goals to leave a legacy. I could go on, but I'll stop there. But the Experience Corps was the first program designed to demonstrate that we could build new social infrastructure for an aging society that would bring out the value of having longer lives and invest in creating those longer, healthy lives. But we need many more models. We need models that drive both the value of the social capital and the health promotion of older adults into every community. Here's what this could mean. This is one group of volunteers in one school in one city in Baltimore. In the middle is the ex-governor of Maryland, who happened to run for president at some point. But all the other people are Experience Corps volunteers, and you can feel the power of the critical mass of older adults serving in the public elementary school, and why that changes the school climate, why it changes the children's optimism about what a long life could look like and what it could mean, and that it's something you could shoot for, and how much it means to them that all these older people care about whether they do well in school. So I'd like to argue to you that there are more potential assets of an aging society than what the second demographic dividend offers, that we have never addressed, whether there are more positives to having longer lives than just more savings. And the key in the lock is health span and whether we extend it, as well as building the social infrastructure that we need to enable the social capital of older people. And so I would argue that we could build a third demographic dividend, a new stage of human development, one in which we actually create roles and responsibilities for older people, that utilize the assets of maturity, enable people to meet their generative needs and goals, organize this unprecedented new social capital to help solve the major unmet needs in our society, and build the future for next generations through those investments, while designing these roles to increase the well-being of people who have had the privilege of living long lives. A third demographic dividend will have to be built on a set of pillars: on health, public health, age-friendly environments, integrated medical, social, and long-term care, and social protections, and building the opportunities of longer lives with enough health and function to be able to engage, that enable the social capital of older people. And if we could design this new life stage to realize the third demographic dividend, I would argue this is the opportunity of the 21st century. And that the assets of older age could actually be transformative for all ages if there's adequate health. So I'll end with a couple thoughts on health span. What's health span? It's the part of a person's life during which they're generally in good health and free from chronic disease or disabilities of aging. How can we do this? Can we do it? Well, just starting from social engagement, the evidence, which I don't have time to go through, is very strong that there's a virtuous cycle between social engagement and health and function. And so the more there's opportunities for people to get up with something of value to do in the day, with meaning and purpose, the more likely to preserve health and function. And I told you a little bit about the health outcomes of experience score, but I think we could generalize that hugely. And it means it does get people up in the morning to have a place to go to where they're making a difference, as this gentleman said. I'm going to skip a couple things here. How can we do this? Well, I'll end by saying that the science of the last 50 years, particularly the public health science, has shown that health is malleable into the older stages. When I was in geriatrics training, that was an argument. It was not a fact. It was an argument being argued by my betters. Would prevention work and matter for older people? Would anyone care? Would doctors prescribe it? Would insurers support it? All unknown. All these years later, what we can now say is that half of all chronic diseases at a minimum are preventable. That the prevention of disease and disability are possible at older ages. That was a question, not a fact, a few decades ago. That older people, just like young people and middle-aged people, benefit from physical activity and nutrition as well as engagement. That healthy environments matter into the oldest stages. We know so much now about air pollution, for example, and how it affects cognitive decline, as well as poor cognitive development in young people. That health disparities are the key. If we resolved health disparities, it would mean that everybody, every older person, would arrive at old age having received the benefits that people with more resources have. And we have to look to what we have not, of all the science that all of you do, we have not yet implemented in the public health system, where 70% of a population's health is created, as well as in medical care. Huge amounts of evidence. I'm not going to go through it, but a lot of evidence about healthy lifestyles, healthy behaviors. But we also have some really interesting natural experiments, which I'll end with. Ken Langa and colleagues reported in 2017 a 25% decline in dementia prevalence in the US from 2000 to 2012, over 12 years. That decline was not across the board. It was in the 25% of older people who had been the beneficiaries across their lifetimes of more education, healthier environments, more public health, better access to medical care, safer communities. That subset has demonstrated for us that it is possible to decrease cognitive impairment and dementia, but that subset is also demonstrating that it is possible to live a long life with health. We didn't know that 20 years ago. We didn't know that. We now know it because of this natural experiment in the US. We also are seeing it globally. Here you see cognitive performance across nations and different regions by age. And what you see is a huge variation at any age group in cognition, from Europe and the US to, in the green, India, in the brown, Mexico, and in the dark blue, interestingly, Southern Europe. So these natural experiments are showing us what the potential is. So I'll end by saying that this is the opportunity for us to figure out how to create, to argue, if you want, whether we could have a third demographic dividend. But if we want to set our sights on that, how we create it. Thank you.